So I wanted to really start out talking a little bit about from the heart first, and then I'm gonna go through kind of our journey to become relevant in our market over the last decade. You know, I think it's really important, and I have college-age kids, and they both went to USC just to piss me off. You know, they're struggling for relevance and what kind of work that they want to do. And one thing about being involved in healthcare is how meaningful it is. And when I was going through graduate school here, it was really clear to me that I didn't want to do consulting. I didn't want to do widgets. I want to do something that I felt was going to be really meaningful to people, that would really touch people. And what I love about academic medical centers and UCSD in particular is that this is the hub of where discoveries are made, translated into treatments, and then brought to the bedside. And so that's the sweet spot that academic medical centers play. It plays here as well at UCLA, as well as the other UCs. That's a big role of academic medical centers, is to accelerate basic science to bedside discoveries and cures. So I wanted to start with just a little story of a patient. And this patient came to UCSD probably about 18 months ago now. And I just want to show you her story to start out the day.
Hey, it's Claire. So I don't know how good this film angle is, but I am standing on top of a mountain, literally. My name is Claire, and I have something called cystic fibrosis.
Claire Wineland first came to my attention through the social media buzz that surrounded her.
And it causes an overload of mucus to form in all of your organs, and it causes different problems in every single organ, right? It's kind of like having 5 or 6 illnesses all wrapped into one nice little package and tied off with an oxygen tube.
She was this sassy, funny, adorable high school kid who was talking honestly about her life with cystic fibrosis.
I have to eat around 4,500 calories a day. For those of you who don't know, that is like the amount of a sumo wrestler.
This is Claire Claus, and I'm going to be singing a couple of selections of songs.
She talked about how people are afraid to be around sick people, how they don't know what to say to sick people.
So one of the biggest things is people are terrified to ask what's wrong with you. Mind if I why you have this? I'm like, oh my God. It's okay to be like, so what's wrong with you?
Now this was her life. She'd always been sick. And so part of her job, as she saw it, was making people more comfortable talking about mortality.
I wanted to talk about death, and I wanted to talk about what it feels like to die. There was no amount of preparation, no amount of thinking about death, questioning the great beyond. None of that meant jack when I actually was dying.
Cystic fibrosis can be terminal. And Claire finally reached that point where she realized unless she got new lungs, unless she gave herself a chance at new lungs, she was going to die sooner than she was willing to accept.
I'm getting new lungs, and it's very exciting and also completely terrifying, but exciting. You know, when I was born, my life expectancy was 10 years old. Now it's like, you know, I'm college age, and I really didn't expect to be able to live. I accepted at like a young age that, you know, that I wasn't going to ever really plan that far ahead in the future. I was going to do as much as I possibly can with what's in front of me. No matter how completely bleak it may look to everyone else, I was going to prove them all wrong and do something with it that I thought was valuable and dignified.
When it became clear that she was not going to recover from this stroke, her parents made the painful decision to take her off of life support. And on September 2nd, 2018, Claire Wineland passed away.
I have a lot of patient stories and videos to show. The reason why I picked this one is because we're not where we need to be yet. And so, you see, it still chokes me up. Part of why we do what we do is for Claire. And I hope that as you get involved in healthcare, that you can feel that kind of passion. You're trying to find new cures. You're going to be involved in digital, innovations. It's about the patient. So moving on to UC San Diego specifically, and our mission and vision feeds right into this whole narrative about really focusing on, and you're going to hear about personalized medicine later on, about how we are focused, our science and our discoveries and our teaching the next generation, but then really looking at the patient individually. For cancer, for instance, now, there's, you'll hear that, breast cancer is really common and breast cancer can be cared for anywhere. But the truth is every cancer is different and every breast cancer is different. And so once you kind of understand that and you can focus discoveries and innovations in that way, it will transform and actually potentially cure cancers. So that's the kind of thing we do at UC San Diego Health. But we didn't start there. I know you're all probably aware of our history, but UC San Diego in general was a highly research-oriented campus. I've lived in San Diego for 23 years. It was really a commuter school to us, really, until about a decade ago. But some amazing things were happening there. I mean, scientists were being recruited, research institutes were being established. We have this whole area now that we call the Mesa that has all the biotech companies, all the research institutes, and it's a really cool area because so much collaboration is taking place. But when it came to clinical care, the basic view was we just need patients for teaching and science. We don't actually need a substantial clinical enterprise. And so when we got through the mid 2000s, the real focus was just on that. Okay, how many patients do we need for teaching and research? And let's focus on our key areas and our key specialties. But we don't need to be that big. And as you know, healthcare has changed radically, and no longer is that the case, and that actually we need to build a funnel of patients so that we can do quaternary care and we can do research and teaching. But if you don't grow the network, you run the risk of being isolated in the market. So when we started in 2012, it was really interesting because San Diego is a really consolidated market. It's a really sophisticated healthcare market. There are 3 major competitors there, Sharp Health, Scripps Health, and Kaiser. And they already had large integrated delivery networks, meaning they already had acquired and built physician enterprises that related to their hospitals. They had purchased a lot of practices in the industry, in the region. And UCSD had kind of come to the conclusion that they couldn't compete locally. And so they started doing things out of market. They started building a cancer center in Las Vegas, and they had some international endeavors that they had going on. And the fact is they were all losing money hand over fist. And so the first thing we did was really to shut that down and to say, look, we're the University of California, San Diego. We have the best physician scientists in the region. We can compete, but we have to build the network to make that possible. And so we really focused a lot on developing the network. So this slide really shows where we were in 2012. You can see, our small La Jolla footprint and, our market share. So we had okay market share in things like cancer. Our overall market share was about 9%. But our competitors were big, and they were well situated. So we were known if you got into really, really big trouble, if you needed a transplant or you had a really unique cancer, you would come to UCSD. Otherwise, just go to Sharp and Scripps and Kaiser. And in fact, we had no primary care vehicles to kind of get patients in. And so part of what we had to think about doing was So how do we build this network? Because Sharp and Scripps and Kaiser are not going to keep sending us referrals. They're going to grow their network so they can keep them all inside, right? So we had to create our own funnel. So what we did, we first thought that we needed to keep our major quaternary services going, but we had to actually prioritize them. So we went through a long process of aligning all the faculty around what were our main areas of focus: cancer, cardiovascular, GI, neurosciences, ophthalmology, et cetera. Those were our aggressive growth areas, and we were really going to put our stake in the ground around those areas, which meant we weren't just going to make investments clinically in that area, we were also making investments in the basic science and research of those areas. So we had really a good focus on the tripartite mission for all of those major areas. And then we started thinking about, well, how do we build out this network? And we thought, I can tell you I thought, because I've been in Southern California healthcare for 35 years, that Sharp and Scripps had probably already acquired all the really good practices, right? So we were kind of going to go in and we were going to look at practices and we were going to just see kind of the worst, the bottom tier of providers in the region. And so what we did is we went out and we surveyed, right? We talked to over 200 physicians in the market who are not related to UC San Diego. And what we found, surprisingly, is that some of the best physician groups were left because they were the ones that were fiercely independent. They didn't want someone to come tell them what to do. They didn't want some big system to start telling them how to run their businesses. But they did realize they needed some protection, right? They needed help with payer contracts. They needed to hitch on to some vehicle to have access to the kinds of contracts that the bigger systems can get. And we were really attractive because we did payer contracting for all of the state. So all the UCs get together when we do payer contracts. So when we're meeting with United or Anthem or any of the other payers, if UCSF doesn't, is getting hosed on the rates, for instance, we all hold out. If UCSD is not getting the rates that they need, we all hold out. And so it gives the University of California a lot of payer clout. I mean, because it's hard to sell product in the state of California without UC in it. And so these groups that wanted to stay independent saw the benefit of hitching themselves onto our payer contracting wagon because our rates were really substantially better in the market, especially for PPO contracts. So we started this effort. We didn't buy the practices, which was the kind of the vehicle in the 2000s. You just go out and you buy a practice, and those worked okay. We actually didn't have that much cash because we were building a brand new hospital. So we only had, I think, 22 days cash on hand at the time, which is horrible. The industry standard is, 60 is like the bottom you're supposed to be. And, you're better off in the 150 to 200 days cash on hand. And so we couldn't just go out and buy practices. But what we did was we created what's called a clinical integration network. And in this network, there would be a signing of affiliation agreements with us, with the practice. They had to agree that we would do clinical quality together, and that was our mechanisms for making sure that they were actually of the quality standard that we need, and then they would be able to integrate, and it would pass. So the group that looks at whether or not we're doing things that are inappropriate in this regard is the FTC. So we needed to make sure we had enough integration between ourselves and the groups that it would pass muster with the FTC, but we weren't getting in their business. We really weren't getting in their underwear about how to run their own business. They just had to make sure that they were able to meet the quality standards. And so that's how we built out, our network. And we didn't own them, we didn't operate them, but they were affiliated with us. So we grew that out, and at the same time, we also worked on other hospital affiliations. So in our region, we looked at how can we relate to other hospitals. And there are a couple of district-owned hospitals, city-owned hospitals, El Centro, Tri-City, Palomar, and they also wanted to hitch themselves onto a larger enterprise in order to get some support in the payer market as well as in clinical care. It's really hard for them to recruit specialists. And so Scripps and Sharp and Kaiser all came and tried to put this deal together with the hospitals, and as did we. And again, we won that competition for two reasons. One, we actually didn't want their basic primary and secondary care. We didn't want commodity care because it would fill up our hospital and not allow us to have tertiary quaternary work. So we weren't trying to move patients out of the market, whereas our competitors were absolutely trying to move patients out of the market into their hospitals. And so that was a sweet spot for us. In addition, it was really hard for them to recruit specialists. And because we were teaching and graduating the next generation of specialists, we had a vehicle to potentially recruit and retain specialists and place them into the hospitals. So the hospitals in the region did tend to select us as their partner. Now, in the question answer, if you want to ask me, I can tell you what actually didn't go well in those affiliations, because it isn't a perfect match. But it did allow us to build out this network. This just shows kind of, if you look at practice acquisition, which was the favored approach from the other systems, versus clinical integration, kind of the pros and cons. So for us, again, we didn't have cash. So one of the biggest advantages for us was that it's a lot cheaper to bring groups into a clinical integration network, because you're not responsible for their salaries or their infrastructure or their staff. It's hard legally, so there was a lot to work through on the legal front in order to make that work. But we weren't responsible, again, for physician salaries, which is the biggest risk factor you have when you buy a practice. Generally, when you buy a practice, it's almost always happens this way, where the physicians really work hard the year that you're evaluating their practice. And then as soon as you buy their practice, they take a vacation. And so, you see a drop in productivity as soon as that's complete. So by not actually acquiring them, we didn't have that risk, so that was helpful. And we didn't have the operating costs. What we did do, though, is that we took our medical record, Epic, we're on Epic, is our official medical record, and we put the groups on our instance of Epic. And in some ways, it's almost more powerful than buying the practice, because the ability to see what's going on, where the referrals are going, how we can streamline care, is really captured in the medical record. And because of having clinical integration, we're able to actually subsidize the EMR in the practices. Epic is a really expensive system. You can ask Atul Butte about that when he's here. I saw him on your calendar for later on today. But being able to deploy it out into the practices, and then it costs about $35,000 a year per physician on our instance of Epic. So that's actually a lot cheaper than being on the hook for $250,000 a year physician salaries. So that was the mechanism that we chose. And then we built out our pop health infrastructure around that. So today, jumping to the conclusion on this, we went from 0 in 2012 of community physicians related to us to 450 today. And they're dispersed through the 3 regions that we spend the most amount of time on. San Diego proper, and we have most of the physician network there. But we also have large primary care groups related to us in Southwest Riverside and Imperial County. Okay, why do we care about that? Well, it turns out, number one, because we're an academic medical center, we're quaternary providers. We need a really large footprint to get the transplants and the VADs and the high acuity care into our facility. And it turns out in Southwest Riverside, looking at that market, when we looked at it, there were about 8,000 discharges coming from that region to San Diego, and almost always going to Scripps or Sharp. And so our play there was to get into that market at a primary care level. So we got involved with the largest primary care group in Southwest Riverside, and to start moving. If they're going to out-migrate anyway, then let's have them come to UC San Diego. So we built that out in Southwest Riverside. And then we built out both a hospital relationship and a physician integration relationship in Imperial County, which has its own challenges. It's the poorest county in the state of California. The hospital, El Centro Regional Medical Center, is the last city-owned hospital in the state. It has no district revenues to bolster it up. So it's a really challenging market. But when we started there, their leapfrog scores, which is an outside external quality measure, they were at F. We took over their emergency department, put in a chief medical officer, worked on their quality, and that district now is at C and almost B in terms of their clinical quality scores. So yes, that's a poor region. Yes, it's a lot of Medi-Cal, but we've really improved the outcomes, I think, for that community. And again, we're not about this because we're just trying to make a ton of money. We do need a good margin to support what we do. But this was really an outreach of trying to address a really big need in an underserved market and making a real difference from a clinical quality perspective. So in 2012, that's what our network looked like. Again, the dark is the unaffiliated. So we had 2 affiliations in 2012 with Rady's Children's Hospital, where our faculty provided care, and the VA, which actually sits on UCSD property, and provided them with faculty care. To today, where we have all of those dots now that create access points for our system and create a geographic footprint that is interesting for payers and employers. Just one story. Before we got to this, Qualcomm, which is one of the biggest employers in San Diego, it was founded by Irwin Jacobs, whose name sits on our hospital. So Qualcomm decided that they wanted to do an RFP. They wanted to take over their own healthcare, and they wanted to create their own ACO. And so they released an RFP, which we responded to, as well as the rest of the systems. And we made it to the very end of that process. But ultimately, even though his name is on my hospital, they chose Scripps. And the reason they did it is because Scripps had a much broader primary care network at the time, and their employees didn't want to change their primary care providers. So if you look at I don't know if you can see it, the 56 corridor in this Rancho Bernardo area, that's where most of the Qualcomm employees lived. And we had nothing there. So now we've built out more access points in the region. And our goal really is for anyone, whether it's a UCSD employee or an employee of a payer product that we provide, is that they can get into us primary care, urgent care, express care within 15 minutes of their house. And opening up that access has become incredibly attractive to payers and to employers because we have much more access points. We're not done. We have a lot more access points to build. We have more in the south to build so that we can really cover this region. But we've come a long way in the 5 years that we've been working on it. It's a combination of our own faculty, clinical integration network partners, and other relationships that have created the access points. So today, when we look at our market share, you can see that cancer has gone from 15% to 21% market share. This is 2018 data, OSHPD data. It's actually gone up from there as well. Our competitors have all shrunk a little bit, and these are the areas that we've really grown in. I think so far the strategy is working. In 2016, we opened up a new hospital, the Jacobs Medical Center, on November 20th. I remember the day we all got together at 5 in the morning, right before Thanksgiving, and opened up the command center and opened up that hospital. And our very first patients were our little neonates that were in Hillcrest, and we transported them. And actually, everyone in the region, Sharp, Scripps, Kaiser, Rady's, helped us bring those babies up the freeway to Jacobs Medical Center. And that hospital filled within 6 months. It was net new 250 beds, and it filled within 6 months. So that's worked really well. It's a lot of debt. It cost $1 billion to open up that hospital. So we brought on a lot of debt service with it, but because we filled so rapidly, we've been in a pretty good financial position since, good operating margin since. In terms of the future, now we're looking back at that old county hospital we took over in 2068, and it is in desperate need of replacing. It is not seismically compliant, so the state will require us to replace that facility. But what's challenging about it is it's not net new, right? It's almost 100% replacement. So here's the challenge we have now that we're looking forward to, and we're working on the answers for this right now, is that we need to replace this 350-bed hospital with a new hospital that's going to cost us $1.2 billion, $1.4 billion, and it's not incrementally new revenue, right? So how do you make that equation work? And that's, if you ask me back in about 3 years, I'll come and give you the answer. We're working on it now. Lastly, I just want to spend a minute on our favorite topic these days, because we've been in the target zone of the coronavirus or the COVID-19 virus. So UC San Diego, sits proximal to Miramar, the Marine station, and about 2 weeks ago, Wednesday, the first of 2 planes landed, and patients were from China, from the province, and came to Miramar. Second plane arrived 2 weeks ago today, and it's been a really interesting experience. We had to stand up our command center immediately. It was clear the county and CDC called around and said, okay, which system is going to take the patients? And there was no question, and this is true throughout the state. It's true here at UCLA and UCSF and Davis as well, that the UCs were really best suited to take this issue on. We have some of the highest nationally ranked infectious disease doctors on our campus, and again throughout all of UC. They kind of have to admit a little bit of guilt, because when they get to deal with a pandemic, they get kind of excited. The rest of us get concerned, but they do get a little excited. So they've been working night and day. We received our first 4 patients 2 weekends ago. They were persons, what we call them is persons or patients under investigation. So they showed symptoms of potentially having the coronavirus. And so it's been an interesting collaboration between the CDC and the county and the California Department of Public Health in managing the patients. We had created an area on the 6th floor where we had built negatively pressured rooms so that the air is sucked in, right, rather than pushed out. So they were put in those rooms on that unit. We got another positive patient who was actually really sick. Gilead had developed an antiviral drug, clinical trial, which we used on the really sick patient. She's still in the hospital today. We're waiting for her results, and for her to get medically stable to release her. In total, in the last 2 weeks, through the command center and all the work that we've done, we've actually spent $1.2 million, which we will be asking the federal government to reimburse us for. We did the same thing for Ebola and actually never got paid, so we're keeping our fingers crossed that we were right on this, and hopefully we'll get those dollars in to offset the expenses. The bad thing that it did, though, is because we became known in San Diego as the coronavirus hospital, is we did see, despite all of the education going on, we did see cancellations of patient appointments and, cancellation of procedures and that kind of thing. So our infectious disease physicians do think this is going to be a pandemic. They think it will run at least to the end of the year. One area that's interesting to think about is that the masks that we use in protective devices for the nurses anyone who's taking care of the patients. There's a shortage of those masks, and they're also manufactured in China. And so we had to call the other UCs and have them send us masks because we were running short on that supply. And today what we're all looking at is, it's not just masks, it's antibiotics and IV solutions and all sorts of things that are produced in China. We're going to have constrained supply chain, we think going forward into the end of the year. So we're gearing up for what that means and how do we diversify our supply chain portfolio to deal with that, and how do we frankly build a stockpile of supplies across UC, because the feds have a stockpile, but they're not going to share it. Criticize them for that. They're just not going to share it. So we're trying to gear up in California for the potential of needing supplies, and so we're putting together our own UC strategy specifically. So that's the highlights of what I wanted to cover. There's so many things to talk about, and I'm really happy to take any questions or thoughts or comments or whatever you want to talk about.
Hi, thank you for a great presentation. Just kind of a question. At the very, very beginning of the expansion journey, what were the conversations, if any, around the notion that the organization, I presume, is a nonprofit organization, and its rationale and thinking about going in and competing for market share as if it were a for-profit organization?
It was a massive change effort and continues today. There's still a contingent of really basic science and researchers who don't believe we actually need to be growing, that we're big enough, we can take care of enough patients, we should stop worrying about this growth, stop spending money in this way. But everyone else, the people that really are paying attention to what's happening in healthcare, they get it. And but I can't tell you that there wasn't a lot of conflict, and there was a lot of challenging conversations. I think what we tried to do, first of all, was to really create that platform for change. And I think this is a really important thing when you're driving the kind of significant change we were, as to what's the story. So for us, the story was, we're underscaled. We only have 22 days cash on hand. If we're going to survive, we're going to have to make some really big changes. So operationally, we did a lot on the cost side to reduce costs, and then we built out this network. The faculty, even today, our physician faculty in our clinical departments, still, they want to control all of that, and they want to say who's in the network and who's not. And so that we had a lot of conflict on that. And we tried to be really respectful of the chairs. If they really felt like some group out there was not of the clinical quality that they thought they should be, then we didn't include them. But there were definitely difficult conversations where we just had to say, look, we have to have network adequacy, right? The payers are looking at us. If we don't have network adequacy, we're not going to be able to do what we need to do to survive. And so sometimes we made hard decisions there, and we still do today. But I would say one thing, I would say probably 12 of the 16 clinical department chairs are on board. We still have a couple stragglers.
You brought it up earlier. What didn't go well during that integration? And also, did you see any changes in your payer mix with smaller IPAs or those private practices?
Really, really good question. So we are today 41% Medicaid. With the state Medicaid expansion, so much, at least a third of the population base is now covered by Medi-Cal. And because we took the county hospital, we have a disproportionate share of Medi-Cal patients. So part of our network strategy, and this is tricky, but was to say, we're not turning our backs on that population. We're fine taking care of that population. We just need to grow the pie bigger, and we need to grow the pie bigger with commercial patients. Otherwise, again, we won't survive. For what we care for at UC San Diego, we underwrite the Medicaid program by about $300 million. So that's a lot to absorb, and so we have to grow that commercial. So picking the right spots to build out the network was really important. That said, we have employees all over the region, and sometimes that's in a poor area of southern, San Diego, and we have to figure out how to support them as well. So, we walk that tightrope. It's something top of mind for us because it's so important for our long-term sustainability.
Hi, great job. David Williams, CEO of Karen. A couple of years ago, I was in a meeting with a competitive CEO, somebody who's been on your slide there, and he said something that I thought was really, really interesting. He said, we need to come up with a strategy and this kind of ties in with your network building strategy,
Yep.
which obviously is working. We said we need to come up with a strategy that says, how do we engage our consumers when they're not patients? What do you think of that in terms of your outreach capability and then the ability to use digital innovation to kind of drive that
Right.
effort?
I mean, I think it's huge. And, I think when we're trying to get more and more of our patients early in their engagement with us onto our medical record, onto my chart, we have apps. And so, and we're developing apps. So I know, again, Atul will be here later today, who leads all of UC for digital and the data warehouse. And, I think it's huge. I think we've got to figure out how best to do that and to engage our consumers. I think we're in our baby stages. I wish we were further along, but I think we're in our baby phases still.
Thank you.
What do you think?
Oh, I could think a lot, and I'll be on a panel at noon, so you guys get to
Okay.
hear you'll get to hear what I think about it then. But
Yeah.
I do think there needs to be more, digital outreach out in the community.
For sure.
I think it also can help with the Medi-Cal populations because technology typically is not built for them. And so the idea of understanding what their experience is can often then drive them to say, hey, you know what somebody does? It's like a branding effort, it's an
Right.
engagement effort, and say, you know what, this is a system that might be good for me. And they don't always go to the emergency department too.
It'll be interesting to that point. It'll be interesting to see whether or not we're strengthening our relationships with the FQHCs, and we have one family health centers that we just started being able to actually schedule into them. And so that kind of connectivity, I think, is going to be important for those handoffs. But another side of this, which is really interesting, I think we rolled out Epic into student health. So we're the only health system that's the campus student health actually rolls up and reports through me, and we put our instance of Epic in student health, and automatically it opens up digital visits, a lot more engagement with the students, but it also creates this opportunity to use predictive analytics. So we're still kind of fighting through student privacy with HIPAA, with where can we find this sweet spot? But if we can do it, our ability to predict students who are going to get into trouble will really go up. And we just want to do that clinical research so badly, and we're just kind of working through the politics of that. It wouldn't happen if they weren't on Epic, but it gives us a huge window into what's going on with them.
Thank you for your presentation. I am Pat Edom, Vice President for Southern California for Health Career Connection. And I just have a question about your workforce pipeline,
Yeah.
in addition to the physicians, but sort of for the UC systems, and then especially if you're feeding into like the Southern Riverside and some of the more low-income areas, what your workforce development looks like in terms of serving a diverse patient population?
Right. It's a good question. So across the University of California, there are 18 professional schools, medical schools, nursing schools, pharmacy schools, et cetera. In San Diego, we do not have a nursing school. We have a pharmacy school, and we're rolling out a brand new school of public health. And then we have the medical school. And so we're producing, residents and fellows that we bring into our system and hire them when they're done, when we can. We work with SDSU, who has University of San Diego, who also has a nursing school, to try to build out that pipeline. We just announced a partnership with the county for working together for the underserved in the mental health area. And part of what that is going to be focused on is not just the production of psychiatrists, but clinical social workers, clinical psychologists. So we're looking at UCSD at those departments and their ability to produce those workers, because that is a really huge area where we don't have enough workforce. And then again, partnering with the other community colleges and SDSU in the region for that workforce development. I have to be honest, I wish we were more developed than we are. We work hard at the diversity of our own workforce. But in terms of developing the pipeline, I think there's a lot more we can do. this deal with the county will give us some funds to begin to do that. Well, thank you so much for having me. Really appreciate it.